Hello, I'm Dr. Jim Stone from the Cummings School of Medicine at the University of Calgary. Welcome to this narrated PowerPoint presentation on Chapter 23, Cardiovascular Protection in People with Diabetes, from the Diabetes Canada 2018 Clinical Practice Guidelines. Before beginning, I would very much like to thank and acknowledge my outstanding co-authors on this chapter, Dr. Robin Holden from Queen's University at Kingston, Ontario, and from Toronto and the University of Toronto, Drs. Peter Lin, Jacob Udell, and Subodh Verma. For 2018, there have been some key changes with respect to new recommendations for second-line lipid-lowering therapy in persons with diabetes who are not at target, the use of new anti-hyperglycemic agents with proven cardiovascular benefit, and a new recommendation regarding the use of ACE inhibitors and ARBs in patients with diabetes but without a history of hypertension. As with the previous guidelines, we have provided a vascular protection checklist. These are the ABCDEs of good chronic disease care management in persons with diabetes. These include optimal glycemic control, usually with a hemoglobin A1C of less than 7%, optimal blood pressure control at less than 130/80, targeted LDL therapy at less than 2.0 or at least a 50% reduction from baseline, the use of drugs that have been demonstrated to provide cardiovascular protection, including, where appropriate, ACE inhibitors or ARBs, statins, ASA for the secondary prevention of cardiovascular disease events, SGLT2 inhibitors, GLP-1 receptor agonists, exercise, healthy eating, and of course, smoking cessation. The emphasis on cardiovascular protection in diabetes stems from the long-standing awareness that persons with diabetes are at significantly increased risk for cardiovascular disease events. However, this seminal article from Dr. Gillian Booth at St. Michael's Hospital in the University of Toronto, published in Lancet in 2006, really serves to demonstrate in an incredibly large patient population that diabetes increases the risk of MI by approximately 50% in both men and women who have diabetes, regardless of their age group. This is data published in the Archives of Internal Medicine in 2001, and it is derived from the Nurses' Health Study. In this particular analysis, in more than 100,000 women, the relative risk of dying from a heart attack was similar in women who had a history of heart disease but no diabetes, as for women with a history of diabetes lasting more than 15 years who are only having their first event. In other words, very high risk. And as you look at the bars in this graph, you will see that for women with a history of heart disease, having diabetes for more than 15 years almost increases by a factor of 4 their risk of dying from their heart attack. So the duration of diabetes is extremely important in terms of the risk of events and the outcomes from those events. The use of the term multifaceted management or multifactorial intervention in the treatment of persons with diabetes in an effort to prevent cardiovascular complications and promote cardiovascular protection refers to utilizing strategies that address glucose control, cholesterol control, blood pressure control, smoking cessation, exercise therapies or physical activity therapies which promote health, appropriate nutrition, and the use of medications which have proven cardiovascular disease lowering benefits in persons with diabetes. The genesis of the use of multifactorial or multifaceted interventions in patients with type 2 diabetes in an effort to reduce cardiovascular complications really derives from this seminal article published in the New England Journal of Medicine in 2003 by Dr. Peter Gady and his colleagues from Denmark. In this very small trial of 160 persons with diabetes, half of the patients were randomized to a multifaceted, multifactorial interventional approach to their diabetes and associated cardiovascular disease risk factors, and the other patients were randomized to so-called standard care or usual care. The idea here was that for people in the intensive arm with diabetes, they would have their cardiovascular disease risk factors controlled as per the prevailing guidelines in Denmark in the late 1990s and early 2000s. In this trial, the patients who were in the intensive therapy group were much more likely to achieve their targets with respect to hemoglobin A1C, cholesterol, and blood pressure. And as a consequence of these improvements in cardiovascular disease risk factor control, there were significant reductions in the incidence of nephropathy, retinopathy, and autonomic neuropathy. Peripheral neuropathy was not affected in this particular population. In the original publication of the STENO 2 trial in 2003, although there were significant reductions in cardiovascular disease events, there was no significant effect on overall mortality or cardiovascular disease mortality. But in the 21-year-old follow-up of this particular trial, you can see that there were significant reductions in all-cause mortality, cardiovascular mortality, again significant reductions in cardiovascular disease events, and significant reductions in retinopathy, autonomic neuropathy, and microalbuminemia. The original trial follow-up was only 8 years, and even in a high-risk population such as those with diabetes, 8 years is simply too short a time frame to demonstrate significant reductions in mortality. However, when you extend the trial on, what you will see is that there are significant reductions in mortality which can be achieved over time. Importantly, in this trial, at the 8-year time point, all those patients who were on standard therapy who wanted to be switched over to interventional therapy had that opportunity. And although most of the people in the trial took advantage of that, they were never able to catch up to the original cohort group in terms of the degree of reduction of cardiovascular disease events. So this observation helped to fuel the idea of metabolic memory and the observation that the longer you can keep people under control in terms of their cardiovascular disease risk factors, the more likely this benefit will extend and become greater into the future. In a pictorial format, this slide summarizes the multifaceted vascular protection approach or strategy. Once again, this includes an emphasis on healthy behaviors with appropriate nutrition, appropriate physical activity and exercise, smoking cessation, and weight management. It also highlights the need for good blood pressure control, good hemoglobin A1C control, and the use of appropriate medications, including statins, ACEs and ARBs, and some anti-hyperglycemic medications. Moving on to cardiovascular medications with protective effects in the setting of diabetes, we will look at statins, ACE inhibitors or angiotensin receptor blockers, certain anti-hyperglycemic agents, and the selective use of ASA therapy. This is data from the heart protection study published in 2002 in Lancet. In this study, more than 20,000 people with documented cardiovascular disease or other high-risk situations such as diabetes were randomized to 40 milligrams of simvastatin or placebo therapy. In the study follow-up period of almost 5 years, the use of statins significantly reduced the risk of recurrent major adverse cardiac events. Within this patient population, the absolute benefit derived by any particular individual very much depended on their risk of subsequent cardiovascular events as opposed to their initial cholesterol concentrations. This is data from the collaborative atorvastatin diabetes study published in Lancet in 2004. In this study of just over 2,800 persons with diabetes, the intent was to observe the effect of 10 milligrams of atorvastatin versus placebo in patients with type 2 diabetes who had additional risk based on retinopathy, albuminuria, hypertension, or smoking. The primary outcome of this trial was reductions in major adverse cardiac events such as acute coronary syndromes, revascularization, and stroke. The median duration of follow-up in this trial was just under 4 years. However, the trial was actually stopped early because of a significant benefit accrued with respect to reductions in major adverse cardiac events in those patients receiving statin therapy versus those patients receiving placebo. The primary endpoint of a reduction in major adverse cardiac events and acute coronary syndromes and stroke were significantly reduced. Overall cause mortality or death from any cause just failed to achieve statistical significance, although one could argue that if the trial had been continued for the full 6 years it was intended to, this endpoint would likely have been achieved. Even though persons with diabetes are at significantly increased lifetime risk for adverse cardiovascular disease events, not everyone with diabetes will derive the same risk from pharmacological interventions, including statin therapy. As stated previously, the absolute benefit that any one individual patient with diabetes will derive from statin therapy depends on their baseline risk. In recognition of that, these guidelines recommend the use of statins in patients who are at particularly increased risk for cardiovascular disease events in the setting of diabetes including those with clinical or symptomatic cardiovascular disease, those past the age of 40, those individuals who have microvascular complications, those individuals who've had diabetes for more than 15 years and are past the age of 30, or who have other indications as indicated in the Canadian Cardiovascular Society guidelines for the diagnosis and treatment of dyslipidemia. As always, women of childbearing potential should only be prescribed statins in the setting of appropriate preconception counseling and reliable contraception. This slide emphasizes that the likely benefit to be derived from statin therapy in persons with diabetes is independent of their initial or baseline LDL level. If their baseline LDL level is less than 2.0 and they are at sufficiently high risk to warrant statin therapy as indicated in the previous slides, then the target would be at least a 50% reduction in baseline LDL concentration. If their target is above 2.0, then the goal would be to get their LDL cholesterol down to less than 2.0. The data supporting this recommendation is derived from studies presented in this slide and the next slide. This is data from the Improve It study performed in just over 18,000 patients with documented cardiovascular and coronary artery disease. These patients were post-acute coronary syndrome and were randomized to simvastatin therapy plus placebo or simvastatin therapy plus ezetimibe. The upper curve in gold demonstrates the significant reduction in event rates in patients with diabetes when they achieved additional LDL lowering therapy by adding ezetimibe therapy to simvastatin. The curve in green indicates that for those individuals who did not have diabetes, there was no substantial benefit from adding ezetimibe. The important caveat here is that if within that group of persons without diabetes, we look specifically only at those individuals at high risk, there was a benefit to lowering LDL. In individuals who are not deemed to be at sufficiently high risk, i.e. low to moderate risk for recurrent events, there was no additional benefit. So this again emphasizes that in persons with diabetes or in persons at increased risk in the setting of documented cardiovascular disease, achieving a low cholesterol level as low as possible is extremely important. And finally, in the arena of lipid-modifying therapy, the latest combatants are PCSK9 inhibitors. Currently, these are Evolocumab and Liraglutide. In this study, the FOURIER trial, more than 27,000 people with documented coronary artery disease and cardiovascular disease were randomized to maximally tolerated statin therapy and placebo, or maximally tolerated statin therapy and the PCSK9 inhibitor Evolocumab. The median follow-up for this trial was only 2.2 years period. However, in persons both with and without diabetes, there was a significant risk reduction in major adverse cardiac events. As demonstrated previously, and as we have been talking about up until this point in time, as persons with diabetes are at greater absolute risk for cardiovascular disease events, the benefit they derive from aggressive lipid modifying therapy is greater than the benefit derived in those at lesser risk for recurrent events, because although they do have documented cardiovascular disease, they do not have diabetes. Importantly, this does not mean that all persons with diabetes require aggressive lipid modifying therapy with statins, Ezetimibe, and a PCSK9 inhibitor. What it does mean is that each patient should be carefully evaluated with respect to the benefits and risks they are likely to derive from lipid modifying therapy, and in most circumstances, the best LDL for any individual patient is the one which can be reasonably achieved with the combination of health behavior interventions and pharmacological interventions as required. The second class of medications felt to have cardiovascular protective effects in the setting of diabetes include ACE inhibitors and angiotensin receptor blockers. The significantly augmented adverse effects of hypertension in persons with diabetes are very well illustrated in the present slide. In this publication from 1993, the presence of diabetes in the setting of hypertension dramatically increases the risk of cardiovascular mortality. And although hypertension increases the risk of cardiovascular mortality and cardiovascular disease events in persons with diabetes, this data from the United Kingdom Prospective Diabetes Study, published late in the last century, indicates favorable benefits that can be derived from better blood pressure control versus less blood pressure control. Also in the late 1990s, results from the HOT trial, the Hypertension Optimal Treatment Trial, were becoming available. This graph demonstrates the effects of graded blood pressure lowering therapy in the diabetes subgroup from the Hypertension Optimal Treatment Trial. Those patients whose blood pressures or diastolic blood pressures were controlled to less than 90 had the highest event rates, compared to those whose diastolic blood pressures were controlled to less than 85 and those whose diastolic blood pressures were controlled to less than 80. This is data from the MicroHope study, or data derived from the larger HOPE trial, which was ramipril versus placebo in patients at risk for cardiovascular disease events. This is data in the 3,500 patients with diabetes who were enrolled in HOPE. And in this sub-study, which was pre-specified, we see significant reductions in the primary outcome of major adverse cardiac events, all-cause mortality, myocardial infarction, stroke, and cardiovascular death. In 2008, Dr. Salim Youssef and colleagues from McMaster University in Hamilton, Ontario, and a team of investigators from around the world published the ONTARGET study. The essential purpose of ONTARGET was to demonstrate whether or not an angiotensin receptor blocker, telmisartan, would be equivalent to an ACE inhibitor, ramipril, in the prevention of cardiovascular disease events in a relatively high-risk patient population. After a mean follow-up of almost 5 years, there was equivalence between talmosartan and ramipril in the prevention of cardiovascular disease events, and there was no obvious advantage in combining the two with respect to the reduction in major adverse cardiac events. In persons with diabetes, irrespective of their baseline blood pressure and irrespective of whether or not they have diagnosed hypertension, the issue is who should receive an ACE inhibitor or angiotensin receptor blocker therapy. And in this issue of the Canadian Diabetes Guidelines, we have done our best to clarify this. These medications should be prescribed irrespective of baseline blood pressure in persons with clinical cardiovascular disease, in persons greater than the age of 55 but with at least one additional cardiovascular disease risk factor or evidence of end organ damage or microvascular complications. Importantly, these medications should be prescribed at the doses which demonstrated vascular protection effects in the original trials, which were Europa for perindopril, the HOPE study for ramipril, and the ONTARGET study for talmosartan. Once again, importantly, in women of childbearing potential, these should only be used in the presence of proper preconception counseling and reliable contraception. Even though these 2018 guidelines reflect the emerging uncertainty as to whether or not RAS blockade is beneficial in persons with diabetes in the absence of hypertension or other cardiovascular disease risk factors, practitioners will do well to remember that the majority of persons with diabetes past the age of 55 almost always require at least one additional blood pressure medication, if not 2 or 3 to get to target, and so most will end up on a RAS agent for blood pressure control reasons. All practitioners are reminded to regularly evaluate cardiovascular disease risk and the need to add in ACE inhibitor or ARB therapy as appropriate. In 2008, after a number of large trials looking at aggressive glucose-lowering therapy as a means of improving cardiovascular outcomes, actually demonstrated harm or potential harm, the Federal Drug Administration in the United States issued a directive that said that any future medications intended to lower blood sugars would have to demonstrate cardiovascular safety. In other words, it was not sufficient to prove that the drugs could lower blood sugars, but they also had to prove that they could do it in a manner which did not increase adverse cardiovascular disease events as a consequence of potentially severe hypoglycemia. In 2015, Dr. Bernie Zimman from Mount Sinai Hospital and the University of Toronto, in conjunction with a team of international investigators, published the EMPA-REG study in the New England Journal of Medicine. In compliance with the 2008 FDA directive that all new antihyperglycemic medications had to demonstrate cardiovascular safety, this trial was undertaken in a new class of antihyperglycemic agents, SGLT2 inhibitors. Not only did this trial demonstrate that SGLT2 inhibitors were safe and free from significant hypoglycemia in this patient population, but there was an unexpected and very significant reduction in major adverse cardiac events. Further analysis of this data revealed that the major reduction in adverse cardiac events was in fact a reduction in heart failure related events. Given the diuretic properties of the SGLT2 inhibitors, this finding is perhaps not surprising. However, in the interim, there still remains significant speculation as to the exact mechanism by which the SGLT2 inhibitors are able to reduce heart failure related events in patients with diabetes. In 2016, the results of the LEADER trial were published. LEADER was a clinical trial comparing Liraglutide, a GLP-1 receptor agonist, to placebo in patients with diabetes. In this trial, similar to the EMPA-REG trial, there was a significant reduction in major adverse cardiovascular disease events. Unlike the EMPA-REG trial with an SGLT2 inhibitor, however, in the LEADER trial with Liraglutide, a GLP-1 receptor agonist, the significant improvements in major adverse cardiac events included significant reductions in vascular events such as myocardial infarction and stroke. GLP-1 receptor agonists are known to have beneficial effects on the vascular endothelium and are known to have anti-inflammatory and antithrombotic properties. Therefore, the effect of the GLP-1 receptor agonists on reducing major adverse cardiac events may be with respect to their anti-atherosclerotic properties as opposed to the anti-heart failure properties of SGLT2 inhibitors. In 2017, the results of the CANVAS trial were published. CANVAS was a randomized placebo-controlled clinical trial comparing canagliflozin, an SGLT2 inhibitor, with placebo in patients with diabetes. There was a significant reduction in major adverse cardiac events. And similar to the EMPA-REG trial with empagliflozin, another SGLT2 inhibitor, the major reduction in adverse cardiac events were related to reductions in heart failure events. In summary, this algorithm demonstrates an evidence-informed approach to achieving glycemic targets and improving A1C control in patients with type 2 diabetes. Healthy behavior interventions with respect to nutrition, weight maintenance or loss, physical activity and exercise, and non-smoking status are always recommended. In patients with type 2 diabetes who have clinical cardiovascular disease and who have not achieved their A1C target, strong consideration should be given to the initiation of anti-hyperglycemic agents with demonstrated cardiovascular disease benefit, such as empagliflozin, canagliflozin, or liraglutide. Lastly, with respect to cardiovascular medications with protective effects, is the use of low-dose ASA therapy. There is a widespread belief that patients with diabetes, particularly those with type 2 diabetes, should be placed on low-dose aspirin therapy for the primary prevention of cardiovascular disease events. However, the evidence to support this belief is incredibly thin. Indeed, despite a large number of clinical trials that has carefully examined whether or not the use of low-dose aspirin therapy in the primary prevention of vascular disease events in persons with diabetes is effective, there is in fact no clear-cut evidence to support this belief. Given the lack of evidence from randomized controlled clinical trials that low-dose aspirin therapy is effective in the primary prevention of major adverse cardiac events in patients with diabetes, there is currently insufficient evidence to support the use of ASA for primary prevention. In these patients, the risks of bleeding are not outweighed by the benefits of cardiovascular disease protection. Lastly, don't forget to do your part to protect their heart. Cardiovascular protection in persons with diabetes is predicated on a multifaceted, multifactorial, but individualized therapeutic approach. It is dependent on team-based therapies that emphasize the importance of treating glucose, lipids, blood pressure, nutrition, weight management, physical activity, exercise, and smoking cessation. And now on to the chapter-specific evidence-informed clinical practice recommendations for cardiovascular protection in persons with diabetes. Recommendation 1. All individuals with diabetes should follow a comprehensive, multifaceted approach to reduce cardiovascular disease event risk, including a hemoglobin A1C of less than 7, systolic blood pressure of less than 130, additional vascular protection medications in the majority of adult persons with diabetes, achievement and maintenance of healthy weight goals, healthy eating, regular physical activity and exercise, and as always, and where appropriate, smoking cessation therapies. Recommendation number 2. Statin therapy should be used to reduce cardiovascular disease event risk in adults with type 1 and type 2 diabetes with any of the following features: clinical cardiovascular disease, age greater than 40, or age less than 40 and one of diabetes duration of greater than 15 years and age greater than 30, microvascular complications, or other therapies that are supported by the Canadian Cardiovascular Society guidelines for the diagnosis and treatment of dyslipidemia. Recommendation number 3. Recommendation 4. ACE inhibitor or ARB at doses that have demonstrated vascular protection should be used to reduce cardiovascular event risk in adults with type 1 or type 2 diabetes with any of the following: clinical cardiovascular disease, age greater than 55 with an additional cardiovascular disease event risk factor or evidence of end organ damage, or microvascular complications. Recommendations 5 through 7. In persons with established cardiovascular disease, low-dose ASA therapy should be used to prevent subsequent cardiovascular disease-related events. Number 6. ASA should not be used routinely for the primary prevention of cardiovascular disease in people with diabetes. However, ASA may be used in the prevention of primary events in the presence of additional cardiovascular disease risk factors over and above that risk contributed by the presence of diabetes alone. Number 7, clopidogrel 75 milligrams daily may be used in people unable to tolerate ASA therapy. Recommendation number 8, in adults with type 2 diabetes and clinical vascular disease, in whom glycemic targets are not achieved with existing antihyperglycemic medications, and with an estimated glomerular filtration rate of greater than 30, an antihyperglycemic agent with demonstrated cardiovascular outcome benefit should be added to reduce the risk of major adverse cardiovascular disease events. And the key messages for this chapter on cardiovascular protection in people with diabetes. Diabetes rapidly accelerates cardiovascular disease and cardiovascular disease event risk. Healthy behaviors and appropriate pharmacological approaches can produce significant reductions in major adverse cardiovascular disease events. Persons with diabetes less than age 30 have a low 10-year or proximal risk of cardiovascular disease events. However, these persons are still at very much increased risk compared to persons without diabetes at a similar age. Historically, pharmacologic vascular protection has focused on blood pressure control and cholesterol control. In the last few years, however, newer antihyperglycemic agents have demonstrated significant cardiovascular disease event reduction outcome benefits, and these medications should be considered, particularly in persons with evident or clinical cardiovascular disease. All pharmacologic cardiovascular protection therapies should consider cardiovascular disease event risk from both a proximate, i.e. less than 10-year risk, and a lifetime risk. Heart failure, even without previous myocardial infarction or in the absence of obvious clinical cardiovascular disease, remain an important cause of morbidity and mortality in persons with diabetes and should be carefully monitored for. The key messages for persons with diabetes remain the same. They are the ABCDEs of good chronic disease care management in persons with diabetes. The vascular protection checklist is simple and suitable to be distributed to all persons with diabetes, as well as individuals in their families. It highlights the importance of a multifaceted approach to the management of diabetes, and it also highlights the importance of healthy behaviors such as nutrition, exercise, and smoking cessation therapies where appropriate. Those of you interested in additional information should visit the Diabetes Canada website. You can also download the app for Google or Apple. And finally, here are the direct hyperlinks for Diabetes Canada and for the guidelines, both for healthcare providers and for your patients with diabetes. I very much hope this narrated PowerPoint presentation has been helpful, and I wish you all the success and all the best in your treatment of your patients with diabetes. Thank you very much for listening.